Today we are going to be talking about plagiocephaly and torticollis and kind of the cascade effect if it goes undiagnosed and untreated. So all the images you'll see here of my are of my own child, and I'll also use him as a small case study throughout the presentation just to show what torticollis looks like in kiddos. Um, so only disclosures is that I do own a PT clinic on Oahu called Three Little Ducks. Previously, I was part of the HPU's DPT program teaching pediatric lab. And then at UH West Oahu, I was teaching a lot of the pre-health courses like anatomy, phys, and kinesiology. And way prior to that, I did do some guest lecturing for the University of Florida's Doctorate of Physical Therapy program and their PEDS program. Um, but we're going to hop straight into it and talk about torticollis. So specifically, we're going to be talking about CMT, congenital muscular torticollis. And typically what that looks like is lateral flexion to one side of the head and cervical rotation to the opposite side of the head. And that's happening because there is unilateral involvement from that sternocleidomastoid muscle. So when you think about that SCM muscle, when it contracts, you see that lateral flexion happen to one side and then rotation happens contralaterally. And so that's the typical presentation of CMT. And you can kind of see that here in this picture of Kashi here, where he's rotated to that side and a little bit side bent in this picture. So the incidence rate of torticollis is actually quite high. So we used to say that we would see torticollis in about 1 to 8 babies, but that incident rate has actually increased to about 1 in 6. And we've seen a change in this incident rate in about the last 5 years. And there's a lot of reasons why that has happened. We're going to get into that in a few moments. Torticollis is actually the third most common musculoskeletal condition in newborns. And we see it most frequently in firstborn children. And there's also a predominance in it happening in baby boys. Not to say that we don't see torticollis in other kiddos. I've definitely had patients where they're fifth, sixth, seventh baby, and they're presenting with torticollis and coming into the practice. So some of the primary signs of torticollis, again, is that head tilt. So what a lot of parents will notice in their babies is when they're looking back at photos, they'll kind of notice their baby is tilted to one side and rotated away. And it's really nice that we have these phones on hand with us all the time because when you start swiping and looking back at photos, a lot of parents, especially grandparents, will notice like, oh, baby has this funny presentation where they always look in the same direction all the time. In certain cases, babies will have that palpable SCM muscle. Sometimes that's because of fibromatosis. And it's not always because of that fibromatosis, but you can see that shortened muscle. It kind of looks rope-like in the baby. And then when you're looking at their range of motion, a lot of them will have difficulty with cervical rotation, lateral flexion. In a lot of the children also, we see limitations in cervical extension. Some associated conditions with torticollis is deformational plagiocephaly that usually goes hand in hand with torticollis, hip dysplasia, facial asymmetries, which also comes from that deformational plagiocephaly. Sometimes we see BPI associated, and then long-term down the road is scoliosis, specifically thoracic scoliosis. Here we go. So here are more photos of my own baby here, and you can see in every photo I have of him, he is rotated in the same direction and he is side bent into the same direction. And you can really see here in this car seat photo how much side bending he has. Um, and all of these photos are all within the first 5 days of his life. So it can present very early on. This photo actually here is the day he was born, and this was day 2 of him. So he was presenting with torticollis straight from the beginning. So some things that we like to do to assess and measure those outcome measurements for these kiddos with torticollis is looking at that passive range of motion, assessing muscle length, looking at their posture, and also looking at those craniofacial asymmetries. And we do that through a couple of ways. One of the big things we use are goniometer, and we have a specific type of goniometer specific just for neck range of motion. It's called a anthropometric goniometer. And then also we use the MFS, the muscle function scale, and that's a great way for us to test muscle length and muscle strength in these kiddos with torticollis. Um, so switching gears, we're going to talk a little bit about deformational plagiocephaly. So these two go hand in hand because if a baby has a preference to look to one side and they're always in that supine position, that is a lot of force going through one part of their head, and that is often the side of the head that will flatten out and form into this deformational plagiocephaly. But we have a few types of plagiocephaly. We have occipital plagiocephaly, where one side of the occiput flattens, frontal plagiocephaly, which happens on the anterior skull. And here we have images at the bottom here of brachycephaly, where the entire occiput area flattens out. And I'm way more sensitive about brachycephaly. For multiple reasons, but typically when I go to educate, I love to tell referring providers, if you start to notice brachycephaly, we really want to make a referral within the first 2 months of baby's life um, to conservatively address it. It's a lot more difficult to round out that head shape with conservative therapy treatment once we make it past baby being 2 months old. So some of the clinical measurement tools that we use in therapy are a handful of things. We use the cranial vault asymmetry index, the cephalic index, the cranial vault asymmetry. If we get really fancy, the plagiocephalometry and the 3D photography. I don't think anyone really here on island or in Hawaii has a lot of these 3D programs. Some of our orthotics guys might, but I don't think there are any therapists on island that have those. But right here, you see an image of a craniometer, and this is really what we like to use in clinic to measure plagiocephaly and keep track of it. And this is the classification system that we use to measure and kind of determine the severity of plagiocephaly in kiddos. So this index comes from the CVAI using this craniometer. So generally in therapy, when patients come to us, if we have concerns for plagiocephaly, we utilize this craniometer typically every session to make sure we're keeping close data on these patients to see if conservative treatment is being appropriate for them and making a change in their life. One thing that I hear a lot about from providers is why is there this increase in torticollis and plagiocephaly? We didn't really hear much about it, 10, 20 years ago, and all of a sudden it feels like there's this surge in presentation of torticollis. And it's for a number of reasons. A lot of it is environmental. These days, babies are spending a lot more time in that supine position on their back. So again, if baby has a preference to look to one side and they're spending a lot of time in supine, it's just furthering that preference for them, and that's increasing that deformational plagiocephaly because that's more pressure going into that side of their head. We also have an increased use in containers. Parents are working. We have a lot of parents who are working from home and don't have childcare. So parents have to turn to utilizing containers like baby swings, bouncers, a variety of items that are on the market. And a lot of those containers, again, are putting patients in that supine reclined position. So furthering that preference, furthering that pressure into their head. Another thing that's most recently changed is mattresses and bedding for babies. Mattresses have gotten significantly thinner and harder, and that's for safety of babies, but that also affects them when we're concerned about these two diagnoses. Overall, we're seeing a lot less kids in that prone positioning. Again, because we are so strong on this back to sleep campaign, kiddos are spending their time at night in supine position, and then also in the day, they're spending a lot of time in supine. And a lot of what we do on the therapy side is a lot of education with parents about how important prone positioning is, how important tummy time is, not just for torticollis, but for the importance of meeting those next set of developmental milestones. Um, and again, lifestyle changes, like I was saying, we have so many parents working from home. Parents are really busy, so that repositioning has changed and it's not happening as frequently. And we're seeing milestones being met later and later and later in this new generation of babies. Um, but we also have some medical reasoning of why torticollis has increased as well. Um, we have had an increase in people utilizing um, interventions like IVF, so people are having a higher rate of multiple births. More preterm babies are being born, and so they're way more fragile and susceptible to that deformational plagiocephaly. And then also on the parent side, I think parents are way more aware of what torticollis and plagiocephaly looks like, and they've become stronger advocates for their kiddos when they come in to meet their referring providers. Some of the big risk factors for torticollis as well as plagiocephaly is being a first-time mom if you're the birthing parent. Having a baby boy, they just tend to statistically are a little bit larger than girls. Having a large baby, so anything over 8 pounds, a long baby, having multiples, and also having a traumatic labor and delivery. So going back to my own child and my experience, I actually hit all of these risk factors aside from having multiple aside from having multiples. And I can say from my own experience, like those last few weeks of my pregnancy, I could feel my baby on one side of my belly, and I kind of knew I had some of these risk factors. I knew when he was born to do that screening for him. If you've met me in real life, I'm not a huge person, and I had a 9 pound baby. I had a very difficult labor delivery experience, so I knew he was at high risk for having torticollis. So now I want to talk a little bit about that cascade of torticollis. Sometimes we hear that, oh, babies will outgrow deformational plagiocephaly, they'll outgrow torticollis. But we have a lot of data and information showing us that there is a chain reaction and huge developmental impacts on these children if it goes undiagnosed and untreated. So first, we'll notice that torticollis present. We'll see those asymmetries present. Then down the road, we'll start to see sensory processing changes, delays in their motor development, and then functional limitations as they enter that school age area. So immediately what we'll see with our little babies is that they'll have those postural asymmetries with that preferential head positioning. So when I go to evaluate a little one, I'm not just looking at their head and neck range of motion, but I'm also looking at trunk, hip, and shoulder range of motion because they're all can be affected by that torticollis. And when a baby has a preference to look to one side, that is their field of vision. So long term, if they have that torticollis that goes untreated and undiagnosed, that becomes their field of vision, and they don't realize that field of vision is much larger. And we also see sensory input asymmetries, which affect their neurodevelopment and feeding difficulties. And this doesn't always mean solids. This also pertains to breastfeeding and bottle feeding. Oftentimes, when we interview patients and their families, parents will report, if they're breastfeeding, baby only prefers breastfeeding on one side. And really, we want to see babies be able to breastfeed on both sides, or if you're bottle feeding, to be able to hold them and bottle feed in each arm. As we get into 6 months and beyond, that's when we start to see delays in milestones or asymmetries in their milestones. Oftentimes, we'll see babies having a preference to roll to one side, having delays in sitting and crawling, and asymmetries in crawling. And I'll have a video to show you shortly about asymmetrical crawling. And then long term, we'll see those postural compensations happen through their body, which then can potentially result in that thoracic scoliosis. And same with that deformational plagiocephaly playing a role in CMT, we'll then see craniofacial development changes as well. So here's a picture or a video of a baby hitch crawling. And we see this very consistently in our patients who come to us with torticollis that goes untreated or is not fully resolved. So you could see this right leg on this baby hitches up, and that's an asymmetrical crawling pattern, and that's not what we're looking for in babies once they hit that crawling milestone. We want babies to be on all fours and hitting a reciprocal crawling pattern. So what this tells me as a physical therapist is that this right hip flexor has been shortened, and probably right trunk side bending is shortened as well, and that's the side of also their torticollis as well. And I'm gonna like chat for just 1 second about the importance of crawling. I know there's been discussion about crawling being removed from the CDC milestone guidelines. Um, I think any physical therapist, occupational therapist will say that crawling is one of the most essential milestones to meet. Um, Crawling is a great way for babies to build that extensor strength in their head, back, and neck. It's also a way for babies to learn to visually screen and scan their environment. It helps build shoulder girdle strength. It helps deepen those hand intrinsic muscles, which are critical as babies go into preschool and elementary school and start to hold writing utensils. We really need babies and children to develop that hand strength in order to participate in writing and handwriting skills. And so now I'm going to talk a little bit more long-term effects as we get into that school age. So we do have evidence showing that, 19% of kids who have a history of CMT are at risk for having developmental coordination issues and delays in gross motor milestones, even when they're well beyond infancy, when they're getting close to 10 years. So one of the most important things when I'm a treating provider is ensuring that that torticollis has completely resolved. If it's not completely resolved, we do see torticollis reoccurring, and it can affect them as they get into the school age. So we have long-term findings showing us that, again, there's coordination issues, balance and postural control challenges, asymmetrical moving patterns, delayed in meeting motor milestones. And motor milestones goes beyond just infancy. We're thinking about running, kicking, jumping as kiddos go into preschool and beyond, and also sport and recreational activity limitations. Then from the fine and visual motor, we're thinking about handwriting difficulties, spatial processing of difficulties, hand-eye coordination deficits, and academic performance issues as well. And we also see CMT and deformational plagiocephaly playing a role in cognitive and learning outcomes. So, like I said, we see a higher prevalence of DCD in kiddos with CMT and DP, concerns with their attention and concentration, visual processing, and their academic performance. And as I mentioned before, kiddos with CMT are at greater risk for having restrictions with their spine mobility and moving into the compensatory scoliosis development. Specifically, we're more concerned about thoracic scoliosis. Um, and like I was mentioning earlier, when we see kiddos with CMT, we're thinking about shoulder range of motion, trunk, and hip range of motion, because down the line, we will see postural asymmetries through that entire kinetic chain if it goes untreated. And then, of course, with anything where there's asymmetries or compensatory movements, chronic pain syndrome is also often associated with it. As I mentioned earlier, hip dysplasia and CMT can be correlated with each other. So at our evaluations, we always do a screening for hip dysplasia as well. So going back to talking about deformational plagiocephaly and its impact on the facial and dental development. Some of the kiddos we see and that we have data for shows that mandibular asymmetry can affect bite and jaw function, and can lead to them needing dental work down the road, and requiring orthodontic intervention. And real quite long term is TMJ dysfunction. I think one of the frustrating things that we experience here in Hawaii is that helmeting is not covered by any insurance here in Hawaii. And this is why it's really important to participate in conservative treatment if we can support those kiddos before they have these huge cosmetic concerns and we can, treat it with therapy. Hopefully we can prevent these long-term impacts from happening on these kiddos. So yeah, we can use 3D imaging to follow their facial asymmetry progression, and that's where our orthotists come into play here for us. Um, and so some of the long-term impacts with these craniofacial asymmetries is vision and eye alignment issues, nasal deviation, which can potentially impact their breathing, ear positioning asymmetry, and this is what we see a lot in our DP kiddos, and jaw development irregularities. This is kind of like a summary of all of what we've been talking about. But some of the big things that I think a lot of families and providers don't think about is not just the long-term impact on, academic involvement, but is also sports, physical, and social impacts. Um, when deformational plagiocephaly goes without intervention, it's really hard for those kids to find helmets. And we need helmets for lots of sports, lots of activities, bike riding, softball, football, baseball. And if a kiddo can't find an appropriate safe helmet for them, they can't participate in that activity, or they're participating in an unsafe way without utilizing a helmet or wearing a helmet that does not appropriately fit them. So when you're talking to your patients, this is sometimes a way to get buy-in with them when you're thinking about recommending intervention or recommending a helmet is talking about sports. I think a lot of parents here in Hawaii love sports and want their kiddos to participate in sports, and them being safe in sports is so critical for all of us as providers. So thinking about like windows of intervention. So the optimal window is right when we're noticing a preference in a baby. So usually that 0 to 3 timeline is perfect. But we can also see babies and kiddos like throughout that whole timeline of at any point where, torticollis or plagiocephaly is noticed in a kiddo. So with 3 to 6 months, we can definitely intervene, and that's when we're starting to see some secondary complications with these kiddos, where they're having asymmetries in their rolling and their sitting patterns. Ideally, we want to be catching kids before they turn 1, because by this point, they've already developed some of those asymmetries in their crawling patterns, pulling to stand using one lower extremity over the other. And then when we get beyond 12 months, this is when the intervention focus really is on maintaining the established patterns and trying to provide that neuro re-education to teach them about where midline is for them. Oftentimes, when we see patients come in who are beyond 12 months, they've established that their tilt is their midline. And so we spend a lot of time doing that neuro re-education, teaching them what midline is. So even if we can get these toddlers to have passive range of motion, we spent most of our time on neuro re-education with them. Even if we can get that muscle length, they just don't understand that midline no longer exists at this tilt and it should exist at midline. So some of the benefits of identifying early is, again, preventing some of those secondary complications, making sure that we are having those kids meet their developmental milestones on time and symmetrically. Also, reduction treatment and duration. That's always ideal for parents and providers, and minimizing those long-term impacts. And from our healthcare, health insurance perspective, it is the most cost-effective way to support these families is as soon as we notice a preference, sending them to the appropriate therapist to support them with that. And then from the family end, it reduces so much stress on those families if we're catching them in those newborn stages. When we're finding babies coming, or when babies are coming to us when they're 6 to 12 months old, it is very stressful for those parents to participate in that home exercise program. Um, and a lot of times they feel guilty that they didn't come in earlier. Um, and again, from that health insurance perspective, it's decreasing that healthcare utilization and we're improving educational outcomes for those kids. We have a great statistic from the federal government showing us that for every dollar that's invested during those first 3 years of a kiddo's life, we have about a $7.50 return back into society. So early intervention works, it saves money, and it increases outcomes for everybody. And here's a long list of all the long-term effects of not treating torticollis and deformational plagiocephaly. Um, and so from my angle as a physical therapist, um, treating torticollis is not just about um, a stretching program. There's so many more components to it because we are trying to intervene in that cascade effect of torticollis. So we think a lot about sensory integration strategy, making sure we're teaching babies about their full visual field, giving them that tactile input, engaging with vestibular integration, and also proprioceptive training. Like I've been talking about so much, the importance of symmetry in meeting milestones. And that's a huge, huge piece of when patients come to our practice. Um, and another piece, especially during the first few sessions with parents, is environmental modifications. We talk a lot to parents about positioning strategies that they can do, how to carry baby to help address their torticollis. How can they move things around their house to address baby's preferences? And also looking at all the containers, devices, and equipment they have, a chair, car seat, a bouncer, and seeing what can we find get more appropriate for that baby. Guidelines, with some changing where that home or relation.
Soma, do you mind repeating that last part? I think you were, unless it was my internet, it was breaking up for me. Oh, I think she's frozen.
Yeah, I think she's frozen. Mm.
Hopefully she'll be back in a moment. Sorry, everybody.
Oh, she logged. Maybe she's logging back in.
Okay.
Oh, there she is. Oh, you're muted, Suma.
Okay, are we all good to go again?
Yeah,
Yeah,
and
do you mind just,
reshare. There you go.
okay. And do you mind going back, maybe about like 20 or 30 seconds in what you were saying? Because right before we lost you, it was all broken up and so we couldn't really hear.
Okay. Did you all hear me talk about environmental modifications?
Yeah, I think that was the last thing you were
Okay.
talking about, like modifying the home, right? So that you would have
Yes.
stimulation on both sides. Yeah. And then I
Yes.
think it was around there that it got crackly.
Okay, perfect. Thank you for putting me back on track. So yes, home modification is a huge piece of those first few sessions in therapy, talking about high chairs, car seats, bouncers, position of where the bassinet is in relation to the parent's bed is also really important. Um, So now we're going to talk a little bit about craniofacial development. I know on here I have talking about going for early helmet therapy for those moderate to severe plagiocephaly patients. Personally, I am very careful in how I navigate that conversation with parents because helmeting is not a covered service in Hawaii. And a helmet can range between $2,500 to $3,000. And when you're thinking about our population here in Hawaii, where 50% of kiddos are on a Quest or Medicaid plan, most of those families don't have that kind of money sitting around waiting to spend on a helmet. Um, I'm always upfront with families and tell them, like, your baby has severe plagiocephaly. These are the other options, but they also know, like, they do not have to take that option if it's not appropriate for them. I never want a family to feel that they need to go into debt or feel pressured by me to make that decision. But I always like them to know what all their options are and what the pros and cons of each choice is. So that's a big piece. And thinking about feeding position, that's something I think a lot about when, especially we're working with our newborns or babies who are breastfeeding. We really want to make sure we're addressing torticollis to put them back on track with having. One of the things that you all can do, because most of you are providers in this room, are talking about or are thinking about how you address your patients when they come to you with questions, and thinking about what kind of questions to ask your patients. So you could always ask your patients, especially our newborns, is does your baby prefer? And yes, you can ask them which side do they prefer looking towards. And you can ask again, if they're lying on their back, they still prefer looking at one side. Uh, Another thing to ask is, do you notice that your baby head look different? Is it flatter on one side than their, does one ear, does it seem a little bit more full than the other ear? Those are all signs that they play.
Suma, I'm so sorry to interrupt you again, but I wonder if you turned off your camera, if we might be able to hear you better, because it's kind of breaking up on and off
Oh,
again.
Yeah, I
oh, I'm
think
so
you need to
sorry.
shut off
Okay.
your camera.
All right. How are we doing now?
I can
Yeah.
hear you fine for the moment, yeah.
Okay, I'm sorry, you all.
No, that's
Um,
okay. Sorry to keep interrupting you.
all good. Another question to ask your patients is about tummy time. How are they doing with tummy time? Are they lifting up their head and looking both ways? Um, are having difficulty looking to one side or the side? Is it harder for them to look up in a direction when they're feeding? So these are real great questions that open up that conversation with your families. So if you're a provider, some of the things you can do is to conducting a visual observation and getting a little bit of passive range of motion. Babies can be tricky. They're very, very smart, and they know how to utilize compensatory movements. So sometimes when you're checking for cervical, babies can utilize a little bit of trunk rotation, not to, using a keen eye. So I really recommend stabilizing baby at their shoulder if you're gonna check their cervical range of motion. Second is also looking and palpating that SCM muscle, looking to see if there's any thickening, if you see a mass, anything that looks rope-like, and just doing a quick cranial shape assessment. If you see any flattenings, any changes in their ear, I refer to T or even OT. There's some will treat both diagnoses. Um, Also talking to these parents, if they're turning or head tilt, if they're reporting that they notice any masses or tightness in that area, or asymmetries with their movement. So in therapy, some of the things that we do is working on stretching, strengthening activity. So a weak muscle. So we want to make sure strength in SCM. Um, and to provide education to any caregiver that's in their child's life, whether it's grandparents, every caregiver's life, to have physician education, like environmental modifications, and neuroeducation.
Suma, I think we're losing you again.
Oh no, no.
sometimes one thing you might be able to try to do if you're not able to move closer to your router is to mute yourself and turn off your volume and then log in from your phone.
Okay.
Oh, you're using a personal hotspot. Okay, that might be why.
How is this? Can you all hear me again? Um,
We can hear you, but it's in and out.
okay.
You can rejoin by calling in maybe, and I can run your slides. Let me get her slides ready.
Okay, can you all hear me again?
Yeah, I can run your slides for you, and then maybe that might help.
Okay. I just opened a clinic a couple weeks ago, so we haven't gotten Wi-Fi yet in the clinic space.
Let me get to the slides, sorry. Okay, here we go.
Yeah, we could go to the next slide and one more slide. And one more, Summer. Okay. So I just wanted to go over some of the environmental changes that we look at for parents, is evaluating all the devices and containers that they're using in their home. So here you can see an image of one of those walkers that are on wheels. And we actually recommend that our families discontinue use of these devices, regardless if they have torticollis or not. Um, and so those are some of the things we like to do with our families, especially with a walker on wheels, these sit-in walkers. It puts a lot of inferior pressure through the hip, and we have data showing us that can actually change the shape of their hip, can delay walking, and can promote toe walking. And we love working with caregivers on their positioning for carrying, feeding, transporting, positioning, playing. Those are all important ways to systemically work on that torticollis. Car seat positioning and fitting is also key. And we work really closely with our CSPTs on making sure we are giving safe guidelines for parents when we're changing some of that car seat positioning. Another thing that's really important is also thinking about baby carrier positioning and fitting. So if a parent is baby wearing, we typically ask them to bring that to therapy so we can look at how that's being positioned and making sure we're using that to our advantage when we're addressing torticollis. We can go to the next one. So these are some common concerns and questions that I get from parents, and that you might hear as well from your families. So the number one thing I hear from families is that they're worried they did something wrong, that they feel really guilty that they didn't notice it. And you can tell your parents like it's nothing that they did wrong. Torticollis is CMT specifically. Is typically from in utero positioning. So it's nothing that they did to cause their baby to have torticollis. And you just continue to emphasize them that early identification and intervention is really key and is very treatable when it's caught early. The other question that I get is, will my baby be in pain during PT? And we try to be as gentle as possible. We're using age-appropriate techniques that are supported by evidence-based practice. And that it should actually like be fun. Usually in the beginning, it is a little uncomfortable because babies are already in those preferred patterns. But once we start to get them into midline and outside of those preferred patterns, it tends to be really fun for the babies. Um, Other big question is how long will intervention take? And it's really dependent on when baby is diagnosed to PT, and also how committed the family is to doing the home exercise programming. And thirdly is just how BB responds. But general guidelines if we see them in that newborn phase is that they usually need 2 to 4 months of intervention. Anything later than that, it increases to about 4 to 8 months. But really the big thing I share with our families is the more committed they are to the home program, the better results we have and the quicker we see those results. I also hear a lot of families get really nervous thinking it's like 3 hours of home programming a day. I try to limit it to about 15 minutes a day of intervention at home. The other thing is that parents think like if they keep waiting, it'll get better. Um, we often don't see that being an effective way to intervene with torticollis and plagiocephaly. Waiting and seeing usually leads to longer intervention, more difficult intervention, and risk for complications down the road. Um, at the very, very extreme, sometimes we see kiddos going in for surgical intervention as well. Yeah, we can go to the next slide. So just looking at our clinical practice guidelines from the APTA, the American Physical Therapy Association, um, this is their guidelines. Early intervention, engaging in passive range of motion, active positioning, parent and caregiver education, strengthening activities, environmental modifications, tummy time, and also manual therapy within PT sessions. And I think after this, we just have some references. I apologize, everyone, for the internet issues.
No problem. It happens. I'm glad we were able to shift and make it work. I'm gonna go ahead and run the poll for our post-session questions. And in the meantime, if anyone has questions, feel free to drop it in the chat for Suma.
Oh, so okay, I see a question about a 16-month-old who can position into midline but still prefers a head tilt. Yeah, so PT would still be appropriate for this patient. It's awesome that they can get into midline. That's usually the hardest part. But the way that this question is phrased, it tells me that there may be some weakness, and that's why they're having a hard time maintaining that positioning in midline. But overall, like they probably would benefit from a PT evaluation to see um, is it something that's related to like more neuro or based on like weakness or limitations in range of motion.
Suma, would you be able to help us a little bit more with understanding your urgency? Like in one of your slides, you had a table that said like urgent, 1 week, 2 weeks. I find that generally most of our referrals take quite a bit longer than that for, oh, I'm an inpatient doc. So, if
Mhm.
I really needed PT, I would, I can get it. But
Mhm.
typically, for like if I admit a baby that's dehydrated from diarrhea and I notice there's torticollis, thank you for kind of educating us all on how serious the consequences can be, because I certainly for one was not aware of that. But I also would probably get the response that we'll see the baby if we have a time, but it might be Saturday night and then by Sunday evening they're ready to go home and then they don't get seen because, PT is really like limited to patients who have active like urgent rehab needs on the weekends, which is totally understandable. And then a lot of times it's hard to get that kind of speed. So
Yeah, I think yeah, it's totally different in like the acute care inpatient setting versus like outpatient. Um I'm talking more about like a referral to outpatient physical
mhm.
therapy for these torticollis kiddos. Um, yeah. So
Um,
even if you see a baby in the hospital where you have concerns for torticollis and the inpatient PT just can't get to them, I would recommend putting in orders for them to see an outpatient physical therapist.
um, Not through the early intervention, because a lot of times those things, I mean, most of our kind of developmental delays and hypotonia and things like that, we tend to sort of be referring to early intervention. But in my limited experience, never having been a client myself, it seems that a lot of things are falling through the cracks and that a lot of the assessments take a long time to happen and so on. But
Yes, I totally hear you on that. I actually used to be an early intervention physical therapist here and for Maui County, and just the process of onboarding and receiving services, if you qualify, can be quite lengthy. It could be 1 to 2 months. One of the wonderful things about outpatient physical therapy is that it can go hand in hand with referral to EI. Patients can have both services at the same time. So if you know that you're referring to EI, you can also refer to outpatient physical therapy, and patients can receive both services. And
Mhm.
um, I know for what it looks like at my practice, but I'm sure it's the same, similar for other practices. We're much faster to have patients on our caseload than probably EI is right now. I know they're very strapped for staff at the moment.
Thank you. Renata had another question asking about whether you had a goniometer that you could like show us how to measure
Oh,
the tilt. If maybe if you turn your video back on, we might, hopefully it would
yes.
work.
Give me 1 second. Let me go grab it.
Thank you.
And everybody answered the post-session survey correctly, so we don't have to review any of the questions.
Oh, that's great. Good job, everyone.
Okay, so this is the goniometer. I know it's hard to see because it's clear, but this is the goniometer that we use to measure head rotation and side bending. So typically you put this goniometer down on the floor or the mat, and then we have baby seated to measure cervical rotation, and then we'll have baby laying supine to measure side bending. I know it's really hard to see because this is a clear device. Um, but Renata, you could always send me an email and I could send you some photos of what this looks like.
And how about for our pediatricians, which, at least half of our participants are pediatricians, several are outpatient primary care docs, who aren't likely to have a goniometer. Would you say that kind of a subjective assessment of motion is helpful in determining like how urgent that referral is? You know, you had talked about like the preference
Totally,
of
yeah.
one side.
I think parent interview is a great tool to use. If a parent can show you photos, or if they're telling you, like, my baby looks to the right 90% of the time, I think that's a great trigger to be like, okay, you should go see therapy, and get that assessed. Um, But if you did want to like manually assess baby, if you are looking at cervical rotation, like I was saying, the really important thing to do is to stabilize here at the shoulder and then assess cervical rotation because BBs, a lot of them will use slight compensatory movements like utilizing trunk rotation to make up for that limitation in cervical rotation. And sometimes it's not noticeable if if it's not something you're assessing regularly.
Um, I'm curious about, I understand a lot of the physical issues that you talked about, but I'm curious as to sort of some of the cognitive and like developmental challenges. Do you think that like the sort of limited mobility and some of those developmental or cognitive challenges have one single cause, or is it really that the torticollis is caused by positioning in utero or some other cause, and then that the torticollis itself affects cognition? Because that seems like not intuitive to me.
Yeah, I mean, I'm not a neurologist, so I don't want to like speak to it completely, but all of this came from evidence-based practice and research papers that we use. I think it's a multifactorial approach when we're thinking about cognitive delays. I think torticollis plays a role. I don't think that is the primary reason why a lot of these kiddos are having cognitive delays, but it's definitely a piece of the puzzle.
Well, I certainly appreciate you kind of like having such a broad overview of it because I don't know about any of my PCP colleagues who are on the call, but for me, certainly as a hospitalist, it was not something that I ever particularly thought about, like, oh, I need to really like attend to this more urgently.
Yeah. Oh, Renata's asking about massage can be safe. Um, okay. So Renata, yeah. So I definitely used manual techniques with my kiddos. Um, and we call it soft tissue mobilization. We don't use, at least in PT, we don't use the word massage, but soft tissue mobilization is the term we use, and that can be very appropriate for certain patients. I don't do mobilization on all of our kids. It is kind of a case by case basis, and it's something that I assess and then determine once I have that patient in my hands.
Thank you. Any other questions from anybody else?
I think that's it. We're happy to give everyone 6 minutes back for their lunch break or to get back to patients. But thank you.
Suma, yeah, thank you. Sorry to interrupt you, Summer. Suma, I was just thinking if you wanted to drop your contact information in the chat, if folks wanted to refer to you, then that would be great for especially I don't know what part of Oahu you're in, but yeah, certainly there's more resources in Honolulu than elsewhere on the island.
Yeah, we just opened a clinic not even 4 weeks ago in the Ala Moana area.
Congratulations.
Yeah,
Congratulations.
thank you. Um, so you can always email us and I can send anyone a fillable referral form to us.
Okay, wonderful. Thank you so much for the education and for sharing your contact information. We look forward to working with you.
Yeah, thank you, everybody. Y'all have a great day.